वो बिलियन बनते बिलियन का महीना है इसलिए रोज पकड़े इनको स्वाब का खाना इतनी मांग रहे हैं बेशक मांग रहे हैं लेकिन खाना तो दे रहे हैं पेट का खाना तो खिलाना स्वभाव है पैसे ना दे इनको मांगने वालों को उनका ध्यान तो पैसे की उन्हें उत्थे छोड़ देना लेके ना
And we have cut down our lectures in that program, and we are holding a very beautiful Meet the Expert program. Although we have given you an ample time of question and answering throughout this course, but there may be still some questions left in your minds. You can ask these questions and their answers from all the eminent experts during the FamilyCon. So that's a big opportunity to learn and giving the final touch and to this knowledge sharing during the FamilyCon. I would like to invite for today's program as a panel of experts, Dr.Arshad Shohood, who is a backbone and pillar of Pakistan Academy of Family Physicians. He is a diplomat from Bagai Institute of Diabetology and Endocrinology, Karachi. I would like to invite Dr. Arshad Shohood. Our second panelist, Dr. Uzma Malik, who is Associate Professor of Endocrinology. She's on the way and would be joining soon. And it's now my utmost honor and privilege to invite my brother, Dr. Khursheed Khan, who has always been a part and parcel of Pakistan Academy of Family Physicians. Although we would be missing him this year in FamilyCon because he's flying to USA 2 days, after 2 days. And we would really be missing Dr. Khursheed Khan in Pakistan Academy of Family Physicians this year's FamilyCon, because he has always been on the forefront of all the academics, not only during the FamilyCon, but throughout the year. Please welcome Professor Khursheed Khan, Professor of Endocrinology and Medicine from Fatima Memorial Medical College and College of Dentistry. Please welcome Dr. Khursheed Khan.
Thank you very much, Dr. Chaudhary, for this very kind introduction. I'm thankful to all of you to spare time out of your busy schedule to come attend this session. Thanks to Getz also to organize and arrange and finance this session as well. So today we are going to talk about the newer agents in diabetes and what are the different, where do they fit in the algorithm as far as the treatment goes. Just a few slides to, you all are well familiar, well aware that we have this huge disease burden of diabetes in this part of the world. Pakistan is number 3 currently at this point, with a total of about 33 million population being diabetic, which will be about 62 million in 2045. So that's a huge number. We have the highest comparative diabetes prevalence in the world in adults between 20 to 79 years of age, and highest proportion of deaths in the world under the age of 60 due to diabetes, which is with about 35%. That's where we stand, being third largest in diabetes. Now, coming to the pharmacological intervention part, I want to show you this slide because this is the ominous octet. These are different pathways through what is going on in our patients with diabetes, that there is, of course, we know there's a decreased insulin resistance if you start from, do you have a laser somewhere? Laser to nahi hai hamare paas na, pointer वगैरह कोई. There's decreased insulin secretion, there's increased glucagon production from the alpha cells within the pancreas, and there is impaired incretin effect from intestine, increased lipolysis, increased free fatty acids, increased insulin resistance, all that translate from that. There tends to be a higher level of glucose reabsorption from the kidneys. The renal threshold for glucose it just resets in diabetic patients. Decreased glucose uptake in muscles because of insulin resistance. There's neurotransmitter dysfunction. There's increased appetite because of that dysfunction. There's increased hepatogluconeogenesis. So all these 8, they are the underlying pathways, underlying problems what we are seeing in diabetic patients. In terms of metabolic, yes, there's much more to that. There is oxidative stress, there is dysfunction of endothelium, there's more production of reactive oxygen species, there are more cytokines, chemokines being produced, which create a low-grade inflammatory response within the whole system in diabetic patients. So if someone could design a perfect medication for diabetes, ideally that medication should address all these 8 different pathways. So a perfect medication should, aside from addressing all those pathways, it should not only reduce your HbA1c, but also prevent beta cell destruction, beta cell apoptosis, control blood pressure, weight reduction, renal benefit should be there, reduce cardiovascular benefit, and there should be minimal or no risk for hypoglycemia in patients who are using that particular agent. So these all 8 points will be an ideal kind of salt I would be looking for in any kind of molecule. And we will come to those molecules. Do we have any of those to address those? I mean, this is a slide from UKPDS. You have seen that there's about, with each 1% reduction in HbA1c, you can see how significant is improvement in microvascular, macrovascular complications in patients with diabetes. So very important to be very proactive in these patients, control their glucose close to normal, as much as close to normal as possible. This used to be, I used to call this trying to keep HbA1c in certain range, treat to failure approach, because HbA1c goes up, you add a second agent, third agent. What we need to do is do a more preemptive approach in these cases. We just need to see what the trend is early on, and then add a second, third agent whenever it's needed, or injectable as soon as that has to be done to keep HbA1c within the desired range. Guideline suggestions, the goal of care is a patient-centric approach. We need to, this is a busy slide. I'm not going to take you through this whole slide. This is basically to show you what we need to do is look at each individual patient, look at the lifestyle of that patient, look at the financial status of the patient, work routine, exercise routine of the patient, and then tailor make those Medicare prescriptions for that patient. So review and discuss with that patient in collaboration with the patient, come up with a plan. So all these things are important, that we should review and agree on treatment plan, assess patient key characteristics, and consider specific factors like comorbidities in that patient. How are we going to give treatment to those patients? And then important part is bring the patient back on with the ongoing monitoring and see how things are doing, and where do we need to change things there. Lifestyle intervention is always the first part for management of cardiovascular and diabetes. Weight optimization, increased physical activity is there. But when it comes to the algorithm for management of diabetes, and we're going to go into the detail after the algorithm, I just want to show you briefly next 2 slides algorithm, and then we'll go on what is the logic behind that, what is the reason why we are using, why these guidelines are there, the reason behind those. So if you look at the algorithm, a patient with diabetes, lifestyle intervention and metformin is the preferred agent for this patient. And after that, you need to categorize that patient. Is your patient someone who has atherosclerotic cardiovascular disease, or your patient is at risk for atherosclerotic cardiovascular disease? Or secondly, does your patient have heart failure, or is your patient at risk for chronic kidney disease? So when you divide this in these 2 categories, then obviously based on guidelines, what agents have been given. Just one more slide, and then we'll go into the details as for why this is so. So someone with a atherosclerotic cardiovascular disease, we're going to prefer GLP1 receptor agonist on that patient. If for one reason or other, like cost issues, side effects, patient cannot use that, then SGLT2 inhibitors can be used as an alternative to GLP1 receptor agonist. But if I flip this to the other side, if I take you to the heart failure and CKD side, in there, our preferred agent is sodium glucose cotransporter inhibitor as the first one. And if the patient cannot use that, or if the patient is using and still not getting to the desired range, then we can add SGLT1 receptor agonist there. For other group of patients, there's more liberty as far as what can you do. So why we want these agents, this is the talk today, why GLP-1 and why sodium glucose cotransporter inhibitors so up in the algorithm there for these patients. Very briefly on GLP-1 receptor agonist, these are glucagon-like peptide, which are produced from the terminal ileum. From the K cells of the terminal ileum, they are produced. And what they do is they work through multiple pathways. They act on your alpha cells and suppress the glucagon production, act on beta cells and suppress and increase the insulin secretion from there. In animal studies, we have seen decrease in beta cell apoptosis as well. Stomach slows gastric emptying somewhat and gives the feeling of fullness, so helps to curb down the appetite in these patients. In brain, it promotes satiety and reduces appetite through the hypothalamic area as well. So it has multitude of effects and pathways through which it works there within the system to improve the cardiometabolic profile of the patients. Now, in GLP-1 receptor agonist, the group, the salts we have available, these are liraglutide, exenatide, lexenatide, dulaglutide, and semaglutide. Some are once daily, some are weekly, like dulaglutide and semaglutide, etc. They are given once a week. Now, the leader trial, which came up with liraglutide, that was one of the very landmark trial. After the problem for cardiovascular issues with medicines, that was highlighted back in 2006. Do you know what happened in 2006? Audience में से कोई एक मुझे बताएगा कि 2006 why it was so important for cardiovascular safety standpoint when the bars were raised significantly by all the monitoring and regulatory agencies. क्या हुआ था 2006 में जी? हाँ जी, रोजिग्लिटाजोन का, very good. रोजिग्लिटा कौन सा trial था? Which trial? Anyone knows? कि कौन सा trial था जिसमें रोजिग्लिटाजोन came out? और मजे की बात ये थी कि रोजिग्लिटाजोन, the trial was published in New England Journal of article was published in NEJM. Rosiglutasone does this, but then at the end they said yes, it increases the risk for MI in these patients. Anyone knows what was the risk for acute MI in patients on rosiglutasone? ये वो तो थी, लेकिन कितना परसेंट था? Anyone knows कि compared with the other group कितने परसेंट increase था? उसमें जो एब्सोल्यूट टर्म में तो मतलब 1.6% था, लेकिन relative risk जो था वो 22% के नजदीक था. अच्छा, कंप्यूटर की saying the battery is running low. इस पे अगर किसी ने adapter चार्जर लगाना तो लगा दें, ये ना हो कि presentation के दरमियान से. So in 2006 what FDA said, because rosiglitazone was phenomena, like a huge phenomena in that part, that in those years. Every patient with NAFLD is using rosiglitazone. PCOS patients were using rosiglitazone. Diabetics, of course, they were. So when they found out this is what is there, so there was a lot of backlash to FDA that you are approving drugs to treat diabetes, and diabetes, the major cause of death. क्या होती है diabetes में? Heart cardiovascular disease. So we are using a drug which is increasing the risk for MI in patients. Yes, it controls glucose, does great job with the diabetic part, but at the same time increases the risk for MI in patients. So based on that, before 2006, there was no regulation with FDA. Like we just had show the data for any drug which is for diabetes that it improves glucose control, and they would approve it. But in 2006, then this new thing was added that every drug which is approved for diabetes or for cardiac disease, the pharmaceutical company has to provide a trial, very, very clear data to show either there's a cardiovascular neutrality or there's an improvement in cardiovascular outcome with that drug. So since 2006, all the drugs which have come to the market, they have for the management of diabetes, they have shown cardiovascular benefit or cardiovascular neutrality. But when the 2012 and 16 were landmark trial because EMPA-REG trial came out somewhere around early part of after 2010, and then this leader trial was done with liraglutide, and that's when we found out how effective, how helpful these drugs can be, these GLP-1 receptor agonists can be just beyond, above and beyond glucose control. What are the beneficial role of these the agents there? So the leader trial was huge trial. If you look at this slide, but there are multiple curves, but this is about all the major adverse cardiovascular events. Acute MIs, heart failures in these patients, total morbidity in these patients, hospitalization for heart failure. If you look at these curves, in all these curves, the liraglutide is faring better than placebo. So obviously there's a better placebo meant for the patients who are using other agents, but not liraglutide. So in this leader trial, beyond any doubt, clearly it was proven, it was shown that these GLP-1 receptor agonists, they improve the cardiovascular outcome in patient above and beyond just control of glucose there. So that's when these newer recommendation, which we are seeing in past couple of years now, they started to formulate, okay, if this drug is so good that not only it controls glucose, but it improves other outcomes, cardiovascular outcomes, MIs, the CV strokes in these patients, and mortality in these patients, then why not to use these drugs as a first line rather to wait for these patients to get these complications and use them as a last agent there. So that's when these drugs were pushed up in that algorithm. Remember, I showed you that algorithm. So that was the reason behind this. This is just the number of trials which were done after the DREAM trial, starting from 2006. And there's many of these trials, but coming to the all these are on DPP-4, SGLT2 inhibitors, and GLP-1 receptor agonists, starting from Examine to say WAR, MI, EMPA-REG trial, which came around the same time, just before the leader trial, I would say it came out. Sustain was there, Canvas was there, and so it just continues to be there. Rewind is a newer one which just came out with dulaglutide. And we'll talk briefly on that part as well. So when it comes to GLP-1 receptor agonists, 5 major trials: ELIXA, LEADER, SUSTAIN, EXCEL, REWIND, and PIONEER trial. With all these agents, and I just summed up towards the end the results of these trials. If you look at this, the major adverse cardiovascular event in all these things, barring ELIXA, with everyone else, hazard ratios around 0.87 with LEADER, 0.74 with SUSTAIN, 0.79 with PIONEER, 0.88. So in all these GLP-1 receptor agonists fared much better than placebo in terms of major adverse cardiovascular event above and beyond glucose control in these patients, when the confounding factor for the difference in glucose in these two groups were taken care of. And now, not only these, we know the obesity is the root cause for all this, for patients with diabetes. Obesity is the root cause for this problem. So in these patients now, what these obese non-diabetic patients, now there are trials available. Liraglutide is one of those we can use clearly for obese patients just for weight loss, regardless whether they have diabetes or not. For patients, the other one with this semaglutide, which is also approved. Very newer molecule was presented very recently in ESD meeting. Hanji, anyone can tell me the name of newer molecule जो obesity and diabetes के लिए अभी recently आया? That newer molecule is terzepatide, which is combination of GLP-1 receptor agonist and GIP as well. So in that molecule, we are seeing the degree of weight loss. What we're seeing with the terzepatide is almost twice as what we are seeing with GLP-1 receptor agonist. Probably it's going to, FDA has put this on fast approval process there. We may be seeing approval of this molecule very soon because they are trying to approve this on a fast track, just based on the results which have been presented very recently in the European Association for Study of Diabetes in this Sweden meeting just last month. Terzepatide, yeah. So coming to the second group of molecules, remember I showed you that in algorithm, GLP-1 receptor agonist and SGLT2 inhibitors, they can push up the algorithm significantly above all those drugs. And that is based on all the data which I just shared with you about GLP-1 receptor agonist, that there is a significant benefit in these patients. But I didn't take in a lot more details, but then the benefit in terms of improving cardiovascular outcome in these patients, reducing weight in this patient, decreasing blood pressure in these patients, decreasing hospitalization for heart failures in these patients, improving the glucose control, of course, at the same time. And these patients are lean compared with the other group because they do cause weight loss in patients. And I have seen in our population, we tend to see higher degree of weight loss with these analogs. Maybe there's a high incidence of nausea in our population clinically, I see, and that may be a reason for that weight loss, but certainly we see that. The second molecule, which is pushed up the algorithm along with GLP-1 receptor agonist right after metformin, is sodium glucose cotransporter inhibitors in there. So you all know the mechanism. Let me just what goes on in the kidneys. The renal threshold for glucose, just a physiological slide for simple refresher of your physiology. As plasma glucose levels rise, the amount of glucose in the GFR increases linearly. Reabsorption also increases linearly until maximum reabsorptive capacity is exceeded. The renal threshold is the tipping point at which the reabsorptive capacity of sodium glucose transporters 2 is exceeded and urinary glucose excretion increases in these patients. If you look at this picture, which I showed you, you can see when the renal threshold in a healthy individual is about 10 millimoles per liter in these patients. So as glucose is excreted in the urine, there's more glucose there, the more glucose gets excreted there. But look at, I want to show you, can anyone tell me the renal threshold for diabetic patients for glucose urea is? 180. That's what we traditionally think, but actually it's not true. 180 is for the normal person, there. But in kidneys, remember what I said, it's a multitude of things. It's just not about pancreas. It's just not about insulin resistance. But at the same time, in these patients who have diabetes, their renal threshold for glucose is increased in these patients much above 180. They don't excrete glucose at 180, but rather they excrete glucose at a higher point. Anyone knows that higher point? 200? Any bigger numbers? अंदाज़े से जा रहे हैं जी, 220 मैंने बोला जी किसी ने. It's about 14 millimole per liter. So if you calculate that in terms of that, it comes around 252 in these patients. Most of these patients, it's an average. Some will have a bit lower, some will have a bit higher. So renal threshold for glucose is increased in these patients with type 2 diabetes as well. So that's why when these drugs really come in very handy there. SGLT channels, there, SGLT1 and then SGLT2 channels. The most important are the sodium glucose transporter 2. That's from the proximal convoluted tubules there. And this is the pictorial presentation on that. Sodium glucose cotransporter inhibitors, the two cotransporters, that's 90% of glucose is reabsorbed through that, which is in an average, depending, a normal person could be about 180 grams per day of that. And sodium glucose transporter 2 channels, they absorb 10% of glucose there from the proximal tubules there. So in these patients, if you look at this, these drugs, SGLT2 co-inhibitors, they are wonderful because by blocking these SGLT2 channels, they decrease this 90% of the absorption which is happening in these patients in the renal tubules in these patients. Canagliflozin is available, DAPA is available, and pagliflozin, ertugliflozin is available. I think the most recent molecule is ertugliflozin, which came out in 2017. So why these drugs been promoted up there? What is the cardiovascular safety in these patients? DECLARE was EMPA-REG and DECLARE. These were the major trials which came out. EMPA-REG was about early part of 2015, if I recall correctly, or maybe latter part of 2014, and DECLARE was in 2018. That these trials came out, and they categorically showed how beneficial these drugs are. In DECLARE, the design of the trial was one limb was using, this was a double-blind randomized placebo-controlled trial where dapagliflozin in one arm, placebo in other one, and then these patients were follow up. There were a total of about 17,000 patients in that trial initially, and the primary endpoints were MACE, the three, I would say, cardiovascular disease, MI, and ischemic stroke, and median follow-up was 4.2 years. And if you look at these patients after 4.2 years, the red line is the one which is a placebo, and the blue one is the dapagliflozin, and you can see very clearly there's a significant improvement in terms of HbA1c, in terms of weight loss in patients who are on dapagliflozin compared with placebo. This is a slide about systolic blood pressure and diastolic blood pressure. Again, you can see these curves, these lines very distant and separate from each other in favor of dapagliflozin. So in patients with heart failure with reduced ejection fraction, the dapagliflozin in that trial reduced cardiovascular death by 38%, with plus hospitalization for heart failure by 38%, just cardiovascular death by 45%, hospitalization for heart failure for 36%, and all-cause mortality by 41%. So quite significant improvement, and these benefits, they are above and beyond the glucose control in these patients. This is earlier trial which I showed, which I said, which was released in 2015. EMPA-REG, again, if you look at this is showing you across the board HbA1c and major adverse cardiovascular events, and you can see again clear verification between these two lines. Red is the one which is empagliflozin, and very clear benefit in terms when compared with placebo. So the cardiovascular safety in empagliflozin, there was 14% reduction in major adverse cardiovascular event in patients with previous MI or stroke. So even in high-risk patients, there was significant improvement. DAPA heart failure trial, which was a continuation of DECLARE, was presented in 2019, and where it showed improvement in heart failure with reduced ejection fraction without diabetes. Let me skip the trial design. Just the results of the DAPA heart failure: 26% reduction in cardiovascular death or worsening, 18% reduction in cardiovascular death, and 30% reduction in worsening of the heart failure in these patients. And then there's third, which was DAPA, extension of the same DECLARE trial, which is the DAPA CKD trial. In patients with CKD, how did dapagliflozin do? In these patients, there was 39% reduction in terms of in these patients, the cumulative incidence, rather I would say, in terms of progression to kidney disease, dialysis, or cardiovascular death was much improved, much better with dapagliflozin limb compared with other by 39%. There was a relative risk reduction in these patients there. So not only in patients with simple diabetes, but with heart failure, with CKD, the sodium glucose co-transport inhibitor showed significant improvement. All-cause mortality was improved there in these patients as well. So the purpose of running you all this data was just taking you through those different, I will say, trials which has evolved these the very first algorithm which I showed you early on, why now we prefer all these agents much earlier in the disease course than later on, and why not what is the primary reason for going with these agents first? Because very few years ago I went for a presentation somewhere, and one of the member in the audience asked me, if we need to control glucose, why don't we just give Daniel to the patient? It controls glucose very well in my patient. Well, he's right, it controls glucose very well, but we are looking for benefits which are above and beyond glucose control. We are looking to reduce cardiovascular mortality in these patients. We are looking to decrease morbidity and mortality in these patients and improve their lifestyle as well. So that's why the I ran that algorithm by you, and then I ran a few trials by you just to sum up the reason why in algorithm why we have those newer agents higher up in the disease in the disease management course. But I think the best part, I think it will be for me, in a country where we have about 33 million patients with diabetes, not to touch the preventive part as well for diabetes. I mean, this is where I would tell you that my passion, my heart is because yes, it's good to treat diabetes. It's good to minimize the complication, but I think the preventive part has to be done first. And very recently, just last year or so, a huge trial, and most of you practice the primary care, and that's why I purposely put this trial up there for diabetes prevention. We know that weight gain is one of the major risk factor for diabetes, aside from the genetics of those patients. So based on that, in UK, what was done, yeah, this is, let me skip this slide. You guys all know, you guys are sold out that weight obesity does cause a high risk for diabetes. So this is a trial, direct trial, which was done in collaboration with GPs in UK. In GPs were in UK, what they did was they divided patients in different groups as far who will be assigned, patients who are assigned to different GPs just for lifestyle intervention. Yes, they were said, okay, fine, you're taking those medication, continue with that, but we're going to give you, schedule you for extra visit with the GP in that area, who will just keep counsel you on along with nutritionists with the diet, with the lifestyle intervention, with your exercise. And what they found out in these patients, this was an open label cluster randomized trial in these patients. What they found out in these patients that there was significant with this intervention, just by scheduling them specifically, there was significant improvement in terms of reducing their weight, in terms of newer patients getting newer onset diabetes as well. And a program like this can easily be done with, of course, I would say, through our provincial government, in collaboration with Pakistan Academy of Family Physician, or in collaboration with mostly, I think, since you guys are at the forefront, you guys see the patient first before you send those patients to me or to someone else, to other consultants. So I think if we can have that kind of program, which has been initiated in the UK through the government, the same way where the provincial government takes the lead on this and involves all the stakeholders. And I would tell you that family practitioners, you are at the forefront, and this can be done wonderfully through organization जो तारक मियाँ साहब के, ताहर चौधरी और आप लोगों की पाकिस्तान एकेडमी ऑफ फैमिली फिजिशियन और दूसरी organizations हैं, can be done. So I will finish my presentation at the note that it's great to have these wonderful molecules to treat diabetes, to prevent complication, but we need to think ahead, and we need to go more towards the prevention of diabetes as well there, because the result, let me just share the results of this direct study. Weight loss of 15 kilo or more in 24% of the participants versus none in the control group. This was without any intervention. Yes, without using any pharmacological agents there. Diabetes remission in 46% of the intervention group versus 4% of the controls. Quality of life improved by 7.2% intervention group versus it decreased by 2.5 in the control group. So it's one of the very wonderful trials for you guys to review. Also, I would suggest all of you, when you go home today, read this trial, this direct trial. It's a wonderful trial done for on the preventive aspect as well, and something on this line needs to be considered. And with this, I will thank you all very much for your patient listening and your time.
Thank you very much, Dr. Khursheed Khan, for such an elaborative talk. I am very much happy that you touched upon this direct trial, which I have already touched during my earlier lectures of this course. And along with direct trial, there was another study called Counterpoint study, which was done in 2012 in Framingham area of UK by Dr. Taylor. And in that study, we have seen that putting the patient on hypocaloric diet, like 700 to 800 calories per day, leads to the reversal or a remission of diabetes for not only for the months, for years and years. And that was basically because of the fact that hypocaloric diet, which is minimum in carbohydrates, leads to the movement of these triglycerides and fats, which has been generated through de novo lipogenesis in the liver. And when you reduce this fatty liver in size and in metabolic aspects, all that, you can reverse your diabetes. We will be talking comprehensively on that topic during our FAMILYCON. बात हुई यहाँ पे एक बड़ा इंटरेस्टिंग चीज थी, खान साहब ने जो शेयर की आपके साथ कि जो डायबिटिक पेशेंट है उनका रीनल थ्रेशोल्ड जो है वो 160, 140, 150 इस रेंज में और 152 मोर प्रिसाइजली होता है। आपको पता है कि कुछ ऐसे पेशेंट्स भी होते हैं जिनका रीनल थ्रेशोल्ड बहुत लो होता है, 180 से नीचे होता है। Have you seen such patients where you have they don't have any diabetes, but they excrete a lot of sugar in their urine? No, the condition is called familial renal glycosuria. This is basically, genetic mutation in some families. They have their renal threshold in the range of 150, 160, and they excrete lots of, tons of glucose in their urine. I have such patient at my clinic, and many of the physicians, Dr. Nanak Ram was telling that he has quite a number of these patients in Karachi. This is some family-specific disease, which is a result of genetic mutation. They excrete urine glucose at a very low renal threshold. इस चीज को 1998 में साइंसदानों ने ये सोचा कि अगर दिस इज द रूट। अच्छा, दूसरी बात यह है कि ये जो पेशेंट हैं, दे नेवर डेवलप डायबिटीज। जब ग्लूकोज रहेगा नहीं बॉडी में, दे नेवर डेवलप डायबिटीज, दे नेवर डेवलप एनी कॉम्प्लिकेशन related to diabetes, obviously, and this is a rare genetic mutation. तो 1998 में साइंसदानों ने सोचा कि this is another way of excreting the urine from your, through the root of your kidneys. So they started researching on it, and first SGLT2 inhibitor was launched in USA after 10 years in roughly about 2008 in the form of Invokana. That was the first SGLT2 inhibitor which was launched in USA. And any idea? आज ये जो हम एक सस्ती सी गोली पेशेंट्स को देते हैं, वो कहता है डॉक्टर साहब बड़ी महंगी, आपने लिख दिया SGLT2 inhibitor. It took about $5 million to invent this medicine or first sort of SGLT2 inhibitor. $5 million American dollars. आज अगर कोई दवा बनाना चाहें तो हमें कम से कम 8 से 10 साल का अरसा और मिलियंस ऑफ डॉलर दरकार होते हैं। और हम वो दवा जब यहाँ पे हमारे यहाँ पाकिस्तान में लेट पहुंचते हैं, पेशेंट्स को देते हैं, कहते हैं डॉक्टर साहब दवा बड़ी महंगी है। उनको पता नहीं है कि इस दवा के पीछे क्या रिसर्च और क्या होता है। सो हाउस इज ओपन। ये एक दो बातें आपसे शेयर करनी थी ना। हाउस इज ओपन। इफ यू हैव एनी क्वेश्चन, वी हैव वेरी एमिनेंट स्पीकर अलॉन्ग विद 2 वेरी एमिनेंट पैनलिस्ट। और हमारी जो दूसरी पैनलिस्ट है डॉक्टर उस्मा, शी हैज आल्सो arrived. She is associate professor of endocrinology and medicine at King Edward Medical University. So the house is open for the question and answer session.
हाँ जी, हेलो।
चलिए नहीं खाना।
मैं जरा लेक्चर थोड़ा सुन रही थी, थोड़ा रह गया आने में। होनी आज हफ्ता है ना
चाहिए और डायबिटीज की वो करते रहे इब्तिदा। अब जब हम ये देते हैं तो उनको रातों को उठ के पेशाब करना पड़ता है। तो बेसिकली तो हमने उनके सिम्टम्स बढ़ा दिए, वो फायदा तो ना हुआ। वो जो इन टर्म्स ऑफ मेटाबॉलिक जो मेटा है उस हिसाब से तो फायदा हो गया, लेकिन जो पेशेंट की एगोनी है, वो तो बढ़ गई।
आवाज नहीं आ रही।
देखिए, एक तो ये है कि
हैं?
पहली बात है कि रात के वक्त आप जो SGLT2 को इनहिबिटर वो ना प्रिस्क्राइब किया करें। आई सी प्रिस्क्रिप्शंस ऑल द टाइम जिसमें लिखा होता है डेवामेट और डाइमपाम 5/80 ट्वाइस अ डे, रात को ना दिया करें। आई एग्री विद यू कि ये एक प्रॉब्लम, रात को अगर किसी को भी उठना पड़े तो वो एक हैसल है, तो उसकी हैसल को ना बढ़ाएं। तो एक तो सुबह के वक्त प्रिस्क्राइब करें, उसके साथ बहुत ज़्यादा यूजली उसमें ग्लूकोज यूरिया तो मतलब आता है, थोड़ा सा उसमें यूरिन पॉलीयूरिया भी बढ़ता है, लेकिन ज़्यादा आई वुड टेल यू दैट कि 80% पेशेंट्स को यूजली इतना वो ज़्यादा नहीं होता कि बॉदरसम हो, लेकिन स्टिल देर आर गुड 10, 15, 20% पीपल के जिन्होंने जाके AC लगा के और बैठे हैं, वहाँ पे प्रॉब्लमेटिक आता है। एंड देन आई एंड अप स्टॉपिंग समटाइम्स ड्रग। ऐसा नहीं होता कि पेशेंट मेरे पास, वही बात जो मैंने पहली स्लाइड्स की थी पेशेंट सेंट्रिक अप्रोच से, तो देर आर सम पेशेंट्स जो आते हैं कि डॉक्टर साहब मैं तो ऑफिस जाता हूँ तो मैं हर वक्त बाथरूम की दौड़ ही लगाता रहता हूँ, AC में बैठे हैं, पसीना आना नहीं, बैठे पानी भी उन्होंने ज़्यादा शायद मतलब रूटीनली पीने हैं, तो ऑब्वियसली पेशेंट, यू नीड टू कीप पेशेंट्स कंफर्टेबल। तो ऐसे उन पेशेंट्स में देर आर सम पेशेंट्स आई वुड टेल यू ऑनेस्टली कि मैंने बिकॉज ऑफ सिम्टम्स किए हैं, बट दोज आर वेरी फ्यू एंड वेरी मतलब फॉर इन बिटवीन के मे बी लेस देन 10% or so. और second habit, I don't prescribe SGLT2 co-inhibitors at night, always in the morning, and usually it does fine, especially हमारे सेटअप में, और कोई ऐसा मसला आता नहीं। इवन US में भी बड़े कम लोगों को ऐसा इशू आता है, लेकिन जहाँ पे आता है वहाँ पे आई एंड अप स्टॉपिंग इट बिकॉज पेशेंट की कन्वीनियंस को भी आपने देखना है। लेकिन लाइक आई सेड, मोर देन 90% of the patients they do fine, and then by this now they are getting, now they're getting the benefit of cardiovascular benefits as well, weight loss as well, drop in their blood pressure, so it's a win-win situation. मतलब लेकिन मैं आपको बताऊं कि मैं तो अपनी आपको प्रैक्टिस बताई है, which makes sense to me. अगर someone tells me to take sodium glucose को ट्रांसफर,
दूसरी बात ये कि जैसे खासा नहीं आता ज्यादा, और वेरी इंडिविजुअल रिस्पांस, कुछ लोगों को आता है, कुछ को नहीं आता, जिनको ज्यादा आता है आप उनको मॉर्निंग पे स्विच ओवर कर सकते हैं। मैडम कुछ कहना चाहेंगे?
With your permission, I would like to add something. Usually, 400 to 500 ml more urine is passed because of SGLT2 inhibitors. When you give SGLT2 inhibitor, hyperglycemia of the patient is controlled as well. तो hyperglycemia की वजह से जो उसको पोलीयूरिया हो रहा होता है, उसका इफेक्ट जो है वो नलीफाई हो जाता है. No doubt 300 to 400 ml of the urine extra is passed, and just as the sir mentioned कि you can prescribe in the morning as well. और इसमें जिन पेशेंट्स को प्रोस्टेटिक हाइपरट्रोफी है या ब्लैडर और पेल्विक पैथोलॉजी है, you may shift on to the other class of the drug as well. And if the patient is very symptomatic, just
आवाज
as
नहीं
the
आ
sir
रही।
mentioned, you have to individualize
आ
the
रही आवाज?
treatment, and the patient
आवाज
is
आ रही है?
having too much polyuria, then you
लेक्चर
can always stop
लेक्चर
that drug. But in summary to say that these two molecules, these two drugs, which sir has already mentioned, they have come up the treatment algorithm, and they have very much other beneficial effects as well. For example, cardio protection and renal protection. If you risk the versus benefit, you risk the you may say the risk of polyuria and the risk of cardiovascular death and all-cause mortality. If they are getting, if the patient is getting that and he's willing to tolerate, then I think it should be continued.
Hypocaloric diet literally means cut or control the carbohydrates and increase your fat and your protein. Hypocaloric means that usually we need around about 2,500 to 300 calories per day. In a hypocaloric diet, hypo means low, caloric means उनकी calories को reduce करना है. So नहीं, इसकी ब्रांड कोई नहीं है. हाइपोकैलोरिक डाइट का मतलब क्या है कि आपने अपनी कैलोरी जी आपने अपनी कैलोरीज को रिड्यूस करना है. 3000 की बजाय 1500 कैलोरीज पे आ जाए. लेकिन जो डायरेक्ट ट्रायल में था उसमें उन्होंने 700 से 800 कैलोरीज पर डे यूज की with controlled carbohydrate and prioritizing protein and filling with the fat.
एक तरह से तो मकसद यही है ना कि जी आप अपना मेटाबॉलिज्म को शिफ्ट कर रहे हैं, कार्बोहाइड्रेट्स को घटा रहे हैं, और ये डायबिटीज तो आपकी है ही कार्बोहाइड्रेट मेटाबॉलिज्म की बीमारी। अगर आप कार्बोहाइड्रेट्स को बिल्कुल रिस्ट्रिक्ट कर देंगे तो नॉट ओनली डायबिटीज विल रिवर्स इटसेल्फ, बॉडी आपके जो इंट्रिंसिक आपका जो फैट है, जो एब्डोमिनल विसरल फैट है, वो भी घटेगा। तो बेनिफिट्स तो इसके बहुत ज्यादा हैं। हाइपोकैलोरिक डाइट करें या डाइट रिवर्सल के लिए आप कीटो डाइट, आजकल वैसे बहुत ज्यादा इसका चर्चा हो रहा है, और बेसिकली ये यही चीज है कि आपको एक मेटाबॉलिज्म को शिफ्ट करना है दूसरे के ऊपर।
अच्छा खासा मैं यहाँ पे एक मतलब मैं अपनी समझ के डायबिटोलॉजी जिसको एक्ट्राजीपाटाइड का जो लेक्चर था मैंने भी फॉर्म में अटेंड किया था, और मुझे वहां से भी उस वक्त कंफ्यूजन रही। Hope you can remove that confusion. You know the natural, the action of. मैडम ये आपसे भी क्वेश्चन है, आप इससे अपना राय दे सकते हैं। The natural action of GIP. Natural action of GIP. Because आज तक जितने भी दुनिया में GLP-1 analogs बने, they were just focusing on दो है ना आपके गट हार्मोन्स जिप एंड ग्लिप, तो जीएलपी पे बने सारे जीआईपी पे आज तक कोई नहीं था बना। द रीजन बीइंग द नेचुरल एक्शन ऑफ जीआईपी इज टू एनहांस द ग्लूकागॉन इन द बॉडी। एक नंबर दो, इट कन्वर्ट्स your nutrients into fat and stores into fat cells, causes obesity. So this is basically a diversion from the basic concept of these incretin therapies. So I am little surprised that why GIP is being now focused to for the treatment of diabetes. And another confusion is that we always use the term GLP-1 analogs. I think it's a misnomer. This is not glucagon like. That the function of glucagon is to increase the insulin, and we are using these GLP-1 analogs to reduce the blood glucose levels. So these are two confusions. I would like to your comments on that. Why we are focusing on GIP? This is against the basic pathophysiology of the hormone.
The point is that glucagon-like peptide, it's based on the morphology, the structure of that peptide. So uski wajah se, it's not necessarily for the function, but for the structure. It looks like glucagon-like peptide, but there's a difference. But it has a very different function. So that's where the name came from. Ab ye ke the GIP that is also secreted from the ileum in response to food. जो दो main incretins हैं वो GLP-1 और GIP है. We never thought in the past that GIP will be that important. We thought the major one is the GLP-1 analog. But now with this newer molecule, we have seen it, और इसमें I think उसकी pathophysiology में like you said कि we never thought it's going to be that.
मैं आपको बताऊँ, मैं अभी भी मेरे मोबाइल में
the data is what
I will send you the paper which was published in USA way back in 2012 somewhere around that. I have still that paper, and it was claimed that GIP can never be used as a therapeutic option for type 2 diabetes because it increases the glucagon and increases the obesity. So this is a 180-degree shift. So I was a bit confused about that.
तो थोड़ा सा इसमें मैं ऐड कर दूं क्योंकि वो पेपर ठीक है, एक पेपर आया होगा, लेकिन I can based on my knowledge and Dr. Uzma can also give her input. GIP we always thought it is similar to GLP, but much weaker molecule than GLP-1 analog.
Yes.
It's never an anti-GLP. वो एक आध पेपर आप निकालना चाहें तो हर तरह का पेपर मिल जाता है, तो इसलिए वो मतलब लेकिन we never thought tirzepatide के डाटा से पहले के combination will be that powerful, के overwhelmingly powerful, के twice the effect of just plain dulaglutide और semaglutide आ जाए उसमें. तो डॉक्टर उज़मा अगर आप उसमें कुछ इनपुट देना चाहते हैं.
I have not been into the details of these newer molecules, but from endocrine point of view, I can tell you there are some molecules because hormones are released in a pulsatile manner. और होता यह है कि अगर वो pulsatility आप उनकी break कर दें, they can act their antagonist of their own. अगर इसकी पैथोफिजियोलॉजी में अगर ये है कि GIP उस pulsatility से या circadian rhythm से नहीं दिया जा रहा, persistent दिया, for example GnRH analogs are sometimes given for precocious puberty as well, for treatment of precocious puberty, because they suppress the pulsatility of the hormones. If the pulsatility of the hormones is suppressed, then it may augment the effect of GLP-1. This is what I think from basic pathophysiology of hormones, if you think of. This may be the reason. जैसे आप कह रहे हैं ना कि ग्लूकागॉन बढ़ जाता है, अगर उसको स्पेसिफिक वे में स्पेसिफिक कॉन्सेंट्रेशन में दिया जाए तो वो ग्लूकागॉन को सप्रेस करेगा. You have to look into the basic hormonal changes, what the cell is going, how the cell is going to respond to the hormones as well.
So it is still to be marketed in Pakistan market, and we will see the results about that. But that's I was talking about the normal human physiology, and in that way, to me, I
so normal human physiology में भी अगर वही हार्मोन डिफरेंट डोज में और पल्सेटिलिटी खत्म कर दी जाए तो अपना ही इनहिबिटर बन जाता है.
ठीक है.
उसमें फिर ये एक पैथोफिजियोलॉजी हो सकती है जो कि आप कहना चाह रहे हैं. फिर उसमें ग्लूकागॉन सप्रेस हो जाएगा जो कि ऑगमेंट करेगा GLP-1 एनालॉग्स को.
जी. अच्छा, एक क्वेश्चन आया था, बड़ा जबरदस्त क्वेश्चन आया था जो खान साहब ने भी पॉइंट आउट किया कि बहुत सारे लोग कहते हैं कि जी डायनिल के साथ भी तो शुगर कंट्रोल हो जाती है, तो मसला तो शुगर कंट्रोल करना ही है. बट इन 2022 and 23 if it is important to control the blood glucose level, it is far more important how you are going, which agent you are going to use. अब इसका जो एक बड़ा एक इसका लॉजिकल सा आंसर है कि जितने भी हमारे जो जैसे खान साहब ने भी अपनी उसमें बताया प्रेजेंटेशन में कि 80 to 90% of type 2 diabetics, they are almost at the verge of cardiovascular disease or already having some silent myocardial ischemia. In physiology, there is a condition which is called ऑनलाइन डॉक्टर्स जिनके माइक ऑन है वो थोड़ी सी डिस्टरबेंस कर रहे हैं उसमें कम्युनिकेशन में, तो प्लीज ऑनलाइन डॉक्टर्स देख लें कि अपने माइक्स को म्यूट कर दें. वी आर रनिंग अ वेरी इंपॉर्टेंट डिस्कशन. अच्छा, देयर इज अ फिनोमेना व्हिच इज कॉल्ड इस्कीमिक प्री कंडीशनिंग. आपको कार्डियोलॉजिस्ट नाज़ साहब आज नहीं आए, वो आपको बताते हैं कि व्हाट इज मेंट बाय इस्कीमिक प्री कंडीशनिंग. ये वो चीज है कि जिसमें पेशेंट को अननोइंगली, उसको पता नहीं होता, उसको माइनर एपिसोड्स ऑफ इस्कीमिया होते रहते हैं, बट ड्यू टू द न्यूरोपैथी एंड ऑल दैट ही इज नॉट एबल टू अप्रिशिएट दैट. दीज माइनर अटैक्स ऑफ इस्कीमिया, दे prepare the patient for the next big attack. So that's why this is called ischemic preconditioning. ये आपके हार्ट की प्री-कंडीशनिंग करता है, prepare you for अल्लाह मियां ने भी तो आपके अंदर मैकेनिज्म रखे हैं ना, तो इस वजह से. So all those older sulfonylureas, they abolish that phenomena, and dianyl is on top of that. So patient on dianyl, they die more of these cardiovascular problems. That's the reason we are looking for newer agents which are cardiovascularly safe. So और क्वेश्चन जी कुछ आना चाहें तो. जी हाँ सर.
पॉलीयूरिया इतना बड़ा प्रॉब्लम नहीं होता, मतलब वो मैं आपसे गुजारिश की कि वो बिल्कुल ऐसा बड़ा मतलब पोटेशियम का भी कोई लॉस इसमें नहीं है सिग्निफिकेंट. पॉलीयूरिया डॉक्टर उज़मा ने भी एक्सप्लेन किया, बड़ा नहीं मतलब इशू होता. लेकिन कुछ पेशेंट्स में बेस्ड ऑन देयर लाइफस्टाइल जरूर ये रहता है कि सम पीपल वांट टू गो इन ऑफिस, उन्होंने पेंट बेल्ट टाई हर चीज पहनी हुई है, दे डोंट वांट टू गो यूज द वॉशरूम कपल ऑफ टाइम्स इवन ड्यूरिंग देयर ऑफिस टाइम, वो दे फील अनकंफर्टेबल. तो दोज आर द पेशेंट्स जहां पे ऑब्वियसली आप उन्हें एक्सप्लेन तो कर सकते हैं कि इसके बेनिफिट्स ही हैं, लेकिन अगर चूंकि आपको डिस्टर्बेंस है, यू कैन नॉट हैंडल दैट, तो एक ऑप्शन तो ये हमसे स्टॉप करते हैं. तो यूजुअली पोटेशियम का इशू तो कभी भी नहीं आया. पॉलीयूरिया का जरूर आता है कुछ पेशेंट्स में, और कुछ में मैंने स्टॉप भी किया है. वो कहते हैं जी ये मुझसे नहीं होता है कि ऑफिस में बैठ के मैं बाथरूम में 3 चक्कर लगाऊं, तो आई या 2 चक्कर लगाऊं. तो कुछ में, लेकिन वो बड़े थोड़े मरीज होते हैं, मतलब महीने, मतलब आप कई महीनों बाद कोई एक आध मरीज ऐसा आ जाएगा कि जहाँ पे करना पड़ जाता है.
And also make it an habit, to get your patients serum electrolyte checks at least once in a year, because most of the time there are so many other reasons for potassium problems. There may be hyperkalemia, there may be hypokalemia. और दूसरी बात ये है कि जिन लोगों को भी आपने ये SGLT2 इनहिबिटर्स पे डालना है, तो उनको टिप ये जरूर देनी है कि वो एक्स्ट्रा ग्लास ऑफ वाटर जो है वो 1 से 2-3 ग्लास वो जरूर पिए, और यकीनन रात को ना पिए, लेकिन दिन में उसको काउंटर करने की जो है, क्योंकि ऑस्मोटिक डाययूरेसिस के साथ उनको उसका हाइपोवोलेमिया का मसला और ये सारे मसाइल आते हैं, तो इस वजह से भी.
इसमें तो सारा डाटा वही तो मैंने आपको शो किया है कि कार्डियो जो डेपा हार्ट फेलियर स्टडी थी, एम्पा के साथ भी ऐसी हार्ट फेलियर स्टडी आ गई है। तो इन सब में वी फाउंड आउट के इनका रिस्क फॉर हॉस्पिटलाइजेशन जो है वो कम हो जाता है, इनकी हार्ट फेलियर्स का इंसिडेंस कम हो जाता है, इनमें जो क्वालिटी ऑफ लाइफ है वो बेहतर हो जाती है। तो ऑब्वियसली ये एक ऑगमेंटेड इफेक्ट हो जाता है जिस वजह से, एंड वी बिलीव सम ऑफ दैट इफेक्ट इज मीडिएटेड थ्रू द डायरेटिक इफेक्ट एज वेल। तो इट्स अ वेरी बेनिफिशियल काइंड ऑफ कॉम्बिनेशन। वो उनके दूसरे डायरेटिक चलते रहते हैं, वी डोंट स्टॉप दोस। ऑब्वियसली अब हार्ट देखें, आप जनरलाइज नहीं कर सकते ना। देखें अगर ताहिर साहब ने आपको कह दिया कि एक पेशेंट को आप दे दें, तो ऑब्वियसली हार्ट फेलियर वालों को तो हम ऐसे ही वाटर रिस्ट्रिक्ट किया होता है, आमतौर पे सॉल्ट भी रिस्ट्रिक्ट किया होता है, किडनी डिजीज वालों को किया होता है। तो मतलब दैट वाज फॉर जनरल हेल्दी डायबिटिक पेशेंट्स को जो प्रॉब्लम्स नहीं है।
एनीवेज थैंक यू वेरी मच फॉर करेक्टिंग मी, लेकिन मेरा ये मकसद है।
Sir, I would like to add one comment as well. If you see the latest guidelines of heart failure, after diuretic, even if the patient is non-diabetic, he is not having diabetes, SGLT2 inhibitors are recommended, and many cardiologists are very happy with that. These are in the guidelines of heart failure. It's a part of treatment of heart failure. ये आप optional नहीं दे रहे, अब ये guidelines में recommended है कि आपने देना है patient को SGLT2 inhibitor for management of heart failure.
जी, any other question या फिर जी? Very good question.
That's a very good and practical question. No, patients who have UTIs, frequent UTIs, या जहाँ पे जो urogenital infections in term of maceration of the skin या candidiasis का risk ज़्यादा रहता है, because they do increase that risk. तो वहाँ पे it should be avoided.
And also a few words on Fournier's gangrene as well, because that's a red flag.
मेरा ख्याल है थोड़े से टॉपिक से बियॉन्ड ना, वो तो उनके साइड इफेक्ट्स एवरीवन नोज। और दूसरा उसमें वो जो अर्लियर बात हुई थी ना, मोस्ट ऑफ दीज SGLT2 inhibitors can be given and should be given once a day instead of twice a day. Someone earlier twice a day की कोई बात किसी ने की थी, तो मैंने कहा कि उसमें कर दूं जी।
लेकिन UTI में ये भी आपने पहले रूल आउट करना, बिकॉज डायबिटीज इन्फेक्शंस लव डायबिटीज। तो पहले ये भी रूल आउट कर दें कि आपने देने से पहले, मेरी वैसे ये है कि मैं बेसलाइन यूरिन एनालिसिस कराता हूँ, ताकि मैं पहले ये देख लूं कि पहले UTI तो नहीं है। इफ आफ्टर दैट यू कैन डिसाइड कि वेदर इट इज एज अ रिजल्ट ऑफ SGLT2 इनहिबिटर जो ऑलरेडी उसकी कोई चल रही थी। तो जब आप देना चाहें तो बेसलाइन, इट्स अ गुड आइडिया टू डू अ बेसलाइन यूरिन रूटीन एग्जामिनेशन। मैडम योर टेक।
इसमें मैंने कहना चाहूंगी पैथोफिजियोलॉजिकली यू आर राइट कि पेशेंट को UTI होने का रिस्क बढ़ जाता है, बट SGLT2 inhibitors also causes polyuria as well. उससे होता यह है कि ब्लैडर के अंदर स्टेसिस ऑफ यूरिन उस तरह से नहीं होता, और UTI का रिस्क जैसे हम समझते हैं कि बहुत ज्यादा बढ़ जाएगा, तो स्टडीज में ये देखा कि उतना ज्यादा बढ़ता नहीं है। और अगर पेशेंट को एक आधा अटैक UTI का है और ट्रीट करने के बाद यू कैन स्टार्ट SGLT, ऐसा नहीं है कि उसको कॉन्ट्राइंडिकेटिव हो गया एक UTI के अटैक। लेकिन जैसे सर ने मेंशन किया कि अगर उसको रिकरेंट UTI है, then you can better avoid that. Otherwise, the risk of UTI is not that very much high, because the stasis is low in these patients.
So thank you very much everybody, and we are going to wrap today's session, and I am very much grateful to our worthy panelists, and most importantly our worthy speaker for today's presentation. Now I would like to invite Dr. Tariq Mahmood Mia to give you some updates for the next coming FamilyCon, and this is going to be, you know, a very high-fi sort of FamilyCon this year.
So before concluding the session, I would like to mention that it's an honor for me to be the part of this talk, and Professor Khursheed Khan is my mentor and my teacher, and I'm his first endocrine fellow from Jinnah Hospital. Not me, but all of his fellows are working at various consultant posts throughout Lahore. Thank you very much. Thank you. Jazakallah.
Thank you. बिस्मिल्लाहिर्रहमानिर्रहीम। थोड़ी सी मैं करेक्शन कर दूं कि ये हमारा लास्ट सेशन नहीं था, 2 सेशन अभी बाकी हैं, लेकिन वो इंशाल्लाह कॉन्फ्रेंस के बाद करेंगे। और एक हमारा कॉन्फ्रेंस में जैसे हम हमेशा डायबिटीज के ऊपर हमारा एक सेशन होता है, तो वो फ्राइडे को मॉर्निंग में ब्रेकफास्ट से शुरू करके तो जुमा की नमाज तक वो चलेगा। अब उसमें क्या है कि 3 प्रेजेंटेशंस हैं, और उसके बाद हमने 3 पैनल ऑफ एक्सपर्ट की डिस्कशन और आपके क्वेश्चन आंसर वो इस तरह रखे हैं कि हमारे यहाँ तकरीबन स्पीकर थे कोई 18 के करीब इस सेशन में और कोई 24 के करीब हमारे पैनल ऑफ एक्सपर्ट्स, उनको हमने मिक्सअप कर दिया, 3 सेशन बना दिए। तो वो तीनों सेशन जो है वो उसी दिन होंगे। तो उसमें आप जितने भी क्वेश्चन आप सोच लें करना चाहें A to Z डायबिटीज़ के मुतालिक, तो वो इंशाल्लाह वो सारी क्वेरीज उसमें नेफ्रोलॉजिस्ट भी हैं, आई स्पेशलिस्ट भी हैं, कार्डियोलॉजिस्ट भी हैं, एंडोक्राइनोलॉजिस्ट भी हैं। तो ये एक हमने एक ऐसा मतलब पैनल उसमें बना रहे हैं ताकि आपकी सारी क्वेरीज जो हैं वो हो जाए। ट्यूसडे को हमने ऑफिस में एक मीटिंग रखी है 3:30 बजे। तो जिन लोगों ने अभी तक रजिस्ट्रेशन नहीं कराई या किसी तरह से उनकी नहीं हो सकी, तो वो ट्यूसडे को हमारा 196 अतातुर्क ब्लॉक जो ऑफिस है उसमें आ जाए ताकि आपकी रजिस्ट्रेशन 27 को इंशाल्लाह कॉन्फ्रेंस शुरू हो रही है और पहला दिन जो है वो अल्ट्रासाउंड का है। तो उसमें भी सेम टाइमिंग्स हैं, सुबह 7:30-8 बजे से लेके पहले ब्रेकफास्ट, उसके बाद 8:30 बजे सेशन शुरू हो जाएगा। और नेक्स्ट डे डायबिटीज़ और नमाज के बाद गायनी ऑप्स का होगा। और फिर सैटरडे को हमारे 3 सेशन है, उसके बाद इनॉग्रेशन है और संडे को 6 सेशन है। तो इसमें तमाम दोस्तों से गुजारिश है कि ना सिर्फ आप खुद बल्कि अपने दोस्तों को भी। मैं आखिर में डॉक्टर उज़मा का बहुत मशकूर हूँ कि हमारी एक ही कॉल पे वो तशरीफ़ लाई, उन्होंने बड़ा अच्छा अपना इनपुट दिया। अरशद का बहुत शुक्रिया और आप तमाम दोस्तों का, और आखिर में गेट्स ने ये इतना प्रोग्राम अच्छा करवाया कि आपने देखा होगा कि आपकी बहुत ज़्यादा अच्छी लर्निंग होगी। मैं आखिर में तमाम दोस्तों का बहुत मशकूर हूँ। थैंक यू सो मच।
Thank you very much.
एक ग्रुप फोटो
Thank you very much. Thank you.
यार ये नेट की तार छोड़ना जरा जर साहब। नहीं तारना नहीं छोड़ना जरा, नहीं छोड़ सकते। केबल उतरेगी इधर आके बैठ जाओ, इसमें उतार। चलो कोई नहीं, खड़े होके कर लेने हैं। नहीं इतने ये 2-3 बार अच्छा था। मेमोरी कार्ड नहीं डलता ठीक है, ट्राईपॉड ਉੱਤੇ ਰੱਖ ਦਿਓ। ਤੇ ਕੈਮਰਾ ਜਿਹੜਾ ਖਰਾਬ ਹੈਗਾ ਬਾਜੂ ਨੂੰ ਭੇਜ ਦੇਣਾ ਯਾਰ ਉੱਥੇ। ਸਹੀ ਹੈ ਕੈਮਰਾ ਤੇ ਮਸਲਾ ਕੀ ਸੀ ਫਿਰ?